This is Dr. Paul. Thank you very much for tuning to our channel this evening. I want to talk a few minutes about fever in a child. As always, I invite you to visit our website at www.drpaul.org. That is www.drpaul.org. So today I want to talk a few minutes about fever in a child. Now, I will be honest. Among all the patients we see with all kinds of diseases, personally, I get more anxiety when I see a child with fever. And rightly so, because the etiology is so vast. And the symptoms and signs, they are not really visible if the child is like less than 3 months age. I mean, there is a fever, but you can miss serious problems. Now, fever is, first let us define it. It's a rectal temperature more than 38 degrees Celsius. That is the definition of fever. You can measure the temperature in 5 different ways in a child. Rectal, that's a very commonly used method. Oral, by mouth. Then axillary, in the armpit. Then number 4, forehead. You can also use forehead. There are liquid crystal strips nowadays. You can measure the temperature using the forehead thermometer. And finally, tympanic. You can use tympanic membranes. And the evolution in technology, folks. I mean, the infrared energy coming out of tympanic membrane can be used to measure the temperature. But there are a few side effects, like you cannot use tympanic membrane measurement in children less than 3 months of age. If their ears are full of wax, you cannot use it. And also if the nurse does not use a good technique, you will get a less accurate temperature. So the fever more than 38, then 5 different ways of measuring the temperature. Rectal, oral, axillary, forehead, tympanic. These are the 5 things. Now let us talk about causes. Causes. The basic mechanism, whenever the hypothalamic set point is raised in response to endogenously produced pyrogens, fever happens, right? It's caused by pyrogens. The pyrogens act on hypothalamus and the set point goes high. That's when we get fever. The causes can be infectious, malignancies can cause fever, autoimmune diseases can cause fever, metabolic diseases can cause fever, and chronic inflammatory conditions can cause. And also medications. There are medications and vaccines can cause fever. And brain tumors can cause fever. And also environment. Sometimes a child is moved from colder to warmer temperature and that child may develop fever. So the causes are so varied. And majority of children, like pediatric, most of the times the causes are self-limiting. Most of the fevers we see are viral infections and they're self-limiting. But the problem is, it's very hard to differentiate what is viral, what is bacterial. That's where the confusion lies. That's where the cost of treatment lies. Now, let me talk about the fever and the history. Now, you need to take a very good history, that is the key. How long the baby has fever, how high the fever is rising, and how often are you giving the medications like Tylenol or ibuprofen? Are there any associated symptoms like vomitings, diarrhea, skin rash? Does the patient has any other medical problems? Is the baby taking any medications? Does the baby have any allergies? How is the fluid intake? How is the urine output? And also, is there any recent travel? Are there any exposure to infectious people? So all of these questions you should ask when the parents come. So history is very important. And that history, it depends on, that history determines how you treat these patients. Sometimes you get a telephone encounter, and in the telephone encounter, it decides whether you are going to see that baby in your clinic the same day or next day, depending on the severity of the fever and the problems. So history, then the physical. You need to do a complete physical examination, because the children, the whole system is affected. You need to do a complete neurological examination, because meningitis can be fatal. So a complete neurological examination, you need to see, is the child looking toxic? What is the hydration status of the child? Is the child looking well hydrated? I mean, if the child is well hydrated, then you can actually send the baby home with a symptomatic treatment. But remember this, folks. Every child, when you discharge them, should have a follow-up plan. Sometimes parents take that lightly, but you need to emphasize that a very close follow-up is needed. Now, if the child is less than 3 months, the fever is more than 40.6 Celsius, the child is crying, you should see them immediately. If the child is crying inconsolably, doctor, the child is never stopping crying, the child is having difficulties to eat and drink, the child has a stiff neck, and the child has a rash on the body with the fever, the child has respiratory problems, he or she is not breathing well, even after I clear the nose, the child is drooling saliva from the mouth and unable to swallow anything. Those are the red flags. When you hear those red flags, you should immediately see that patient. But as child's age increases, you see, the good thing is to classify this. If the baby 1 month to 3 months, 3 months to 36 months. Those are the 3 divisions when we deal with children with fever. The first 1 month is very important. Then 1 month to 3 months. 1 month to 3 months is a different classification. And in these children, if the fever is present more than 24 hours, if the fever is more than, and it came back, and the fever is present for more than 72 hours, there are associated symptoms, then you need to see these kids also, at least in the next 24 hours. So what I'm trying to tell you is, in the first 1 month, look for red flags. And the patient's age, the child's age is very, very important when we see this. And what are the underlying conditions? Are there any infections recently? And is the child appearing toxic? Is the child appearing dehydrated? And are there any focal neurological signs? So these are the things for red flags for bacterial infections. And if the child looks well hydrated, non-toxic, then you can give oral antibiotics and send them home with a follow-up. And the other thing is, when you don't see a focus, there are fever without any focus. I think that is the biggest pain in the neck to treat a child without any focus of infection. I mean, if you see a child with otitis media and fever, you give an antibiotic and send them home. Sometimes you look into the ears, you look into the throat, you listen to the lungs and heart, and you examine them completely and you don't find anything. And that is the toughest part. You got to do the labs like CBCs and imagining like chest x-rays and urinalysis, because children can have occult bacterial infections. And now we have good vaccines. We have good vaccines against Haemophilus influenza type B and a good vaccine against Streptococcus pneumonia. Thank God for them. And they are reducing the invasive bacterial infections. But still, the vaccines are not 100% effective. Also, there are other bacteria that can cause serious bacterial infections beside Haemophilus influenza and Streptococcus pneumonia. So ask about vaccine status in all children. Are the children vaccinated well? So if you take all that history and physical examination helps to determine what needs to be done. And you give appropriate antibiotic based on that history, physical examination, and labs. So history, physical examination, lab, all of them are important. And as I said, first 1 month, 1 to 3 months, 3 months to 36 months. In the first 1 month, if the child is toxic, you got to treat that patient immediately. You need to hospitalize the baby, and you should start the baby on parenteral antibiotics, because under 1 month you don't want to take any chances. I mean, even if they have meningitis, they may not show neurological signs. So under 1 month, you don't even depend on neurological signs. You got to treat them. You do CBC, blood culture, urinalysis, urine culture, gram stain, protein, glucose, chest x-ray. And these tests are very important. And whenever you are doubting meningitis, you should take even CSF. So the tests are very, very, very important. And the suspicion is very, very important. And below 1 month, sometimes the babies get neonatal herpes. Sometimes as they come through the birth canal, they get the genital herpes from the mother. And you need to ask again, when you talk to the mother, you need to ask, do you have any history of herpes? Do you have any history of group B streptococcus? Nowadays we are testing all pregnant women for group B streptococcal status. So you should ask the mother, what is your group B streptococcus status before delivery? If it is positive, was it treated? You see, folks, the history is very, very important. And group B streptococcus is the most common cause for bacterial infections in infants. And you need to talk about vaccines. You need to talk about anybody in the home with meningitis and pneumococcal infections. So the history, take a broad history, broad physical exam, and all these tests, and treat with parenteral antibiotics after admitting the patient in the hospital. So for the first 1 month, you do all these things. And from 1 month to 3 months, little bit laxity. you can take little bit of laxity. And because as the children grow up, their signs and symptoms, they show up more easily than the neonates. The neonates, those little things, they don't show you everything. But as children grow up, you will see more things. In terms of manifestation of those symptoms in each organ. So when you see 1 month and below treatment, from 1 month to 3 months, it depends on the toxic level and WBC count. If the WBC count is like 5,000 to 15,000, and that's even 15,000 is high when there are symptoms. So WBC count plays an important role in the treatment of these patients, and you need to do a urinalysis. If it is normal, that is good. And if the patient has diarrhea, and test the stool, how many WBC per field. So if the patient looks non-toxic, low-risk infants, and you can actually treat them in the outpatient with close follow-up. So well-hydrated, non-toxic baby is ideal candidate for outpatient antibiotic treatment with close follow-up. Toxic means go for the testing. And you should also see whether you need CSF analysis. Does the baby need a lumbar puncture? And so those are the questions you need to ask. Today we have immunizations, and we are preventing so many invasive pneumococcal infections, and pneumococcal vaccine, the serotypes are increasing year after year. So it's a good thing that we can prevent the risk of so many bacterial infections, but still there are bacteria that can attack, and they are common in this age group from 3 months to 36 months. So in this age group, 3 to 36 months, or anybody above 3, if the temperature is 39 or higher, take a urine culture, do CBC, and if the child look toxic, do a blood culture, and if there are any neurological signs, do a CSF. So those are the things, folks, I want to emphasize. And also I forgot to tell you, chest x-ray. Chest x-ray, every time you see breathing problem, fever plus respiratory problems, you need to consider a chest x-ray. And also in children, when the WBC count is like more than 20,000 and the patient has no respiratory symptoms, can you do a chest x-ray? The answer is yes. Whenever there is fever in a child with a high WBC count, more than 20,000 cells per mm cube, even in the absence of respiratory symptoms, you should still do a chest x-ray. Why? Because of the occult pneumonia. Sometimes pneumonia starts in the lungs, gives out fever, but no other symptoms. To find that, you need a chest x-ray. So whenever there is WBC count more than 20,000, you need a chest x-ray, and you need to start these patients on empiric antibiotic therapy and follow them closely. And the temperature severity is also more important. Whenever there is a high temperature, high WBC count, you should start them immediately on antibiotics. But if WBC count is low, fever is not that high, child does not look toxic, child does not look dehydrated, in those cases actually observation is a good idea. even without antibiotics sometimes. Because you see, most of these fevers are viral. They are self-limiting. I mean, that's the good news. But, as I said, in certain cases, that should not make us lax, because there are other serious causes. Now, in the treatment, the other most important thing is parental reassurance. You should never leave a parent without reassuring them when they bring you a child. Because you see, parents, they get so anxious when their child gets a fever. I mean, they know that it is viral, but still, the very thing, the fever itself, makes them anxious. Many parents think that fever hurts the child's organs. Many of them think that fever can cause brain damage. They worry about the intelligence of their child. So they come to you with so many anxieties. And folks, that's very important moment to reassure and educate the parents. Sometimes children with high fever get febrile seizures. And when the parent brings a child with febrile seizures, I mean, I can't explain how much anxiety they have. And you need to reassure them. Febrile seizures are harmless. They don't cause brain damage. And even regular fever without seizures. When parents have these concerns, you should always tell them that fever does not cause brain damage. Even like 47.6, like a very high fever, like 107. Anything below 107 does not cause brain damage. So these children don't have brain damage. So folks, spend some time even with the parents. So parental counseling is also an essential part of treating a child with fever. And how to treat the fever itself. Forget about the cause. How can you bring down the temperature? Tylenol, ibuprofen. So if the child is more than 2 months of age, you can start them on Tylenol. Acetaminophen given in the dose like 15 milligrams per kg of body weight. You can give them like every 4 to 6 hours. So give Tylenol. And the other option is ibuprofen. Ibuprofen you can use like 10 milligrams per kg every like 6 to 8 hours. So Tylenol 15 mg per kg every 4 to 6 hours. Ibuprofen 10 mg per kg every 6 to 8 hours. These two are most commonly used medications. Both have a similar efficacy and a similar safety. But ibuprofen is longer acting. So ibuprofen acts longer than Tylenol. The other very, very important point I want to mention here is aspirin. You should never use aspirin in a child with fever, in an adolescent with fever. Why? Aspirin can cause Ray's syndrome, particularly in a child with influenza or varicella. So that's a very, very important point, folks. Hundreds of questions have been asked on that point alone. Aspirin should not be given to any child or adolescent with fever because of its association with the development of Ray's syndrome, particularly during infections with varicella and influenza. So those are the most important points. The other thing is to educating the parents about Tylenol and ibuprofen. You need to counsel them the poisonous side effects if they give overdoses of acetaminophen while treating the fever. So those are the things. And briefly, folks, fever. How to measure it? 5 different types. The causes, I have told you different causes, and the clinical features and the diagnosis. I said different kinds of tests. We talked about age. First 1 month, 1 to 3 months, 3 months to 36 months. Divide into those 3 groups. That helps a lot in managing these children. And finally, we have talked about antipyretics and antibiotics and parental reassuring. Those are the most important things. Hopefully, they help you out. Thank you very much. Please post your points and also visit us at www.drpaul.org. Thank you. Have a nice day.